All right. Good morning. At least it's morning here. My name is Ryan Kennedy, and I'm an FTO with Apollo MedFlight. We're going to be talking about, as you can see, general medical, the assessment and initial management of the medical patient. Now, most of this stuff should be review for everyone, but it's good to go over and get some pearls out of it, good refresher, and there's going to be a lot of crossover that we're going to see. Between the assessment portion and the initial management. Now, a lot of this stuff, as we can see on here, the overviews, I've pulled from our SMPs, our standard medical protocols, standing medical protocols, specifically 190 and 220 and 265. We're also going to talk a little bit about pain management and what those protocols that kind of go along with the whole theme of our generic medical patient assessment stuff. So moving on, define our guidelines. This is on our very first page, S&P 100 out of our guidebook that we have. And I want to go over this portion because it really puts an impression of how we view these and these protocols and guidelines, because you look here, these standing medical guidelines are not intended for the practice of cookbook medicine. They do not take the place of experience and clinical judgment. Used properly, these medical guidelines will serve as an adjunct to patient care in the transport setting. So really, these are just a jumping off point is what that essentially is saying. We don't want to have cookie cutter care, because at the aeromedical flight level, we should be at the peak of our profession. We should be clinicians that have a brain and are able to function in adverse settings and perform the best medical care possible. That's really what I wanted to impress upon by going over this part, just so you can go into the rest of the SMPs with the knowledge that this is a jumping off point. This is the bare minimum that we're expected to do. And we're also expected to exceed the bare minimum. So our general medical assessment here, you've got two sections. You have your primary survey and your secondary survey. And this is all stuff we've gone over before, hopefully, several years ago when you started your career with our A, B, C, D, E, and our vitals, chief complaint, all that stuff. All this should be a refresher, but we'll cover the primary survey a little more in depth in the secondary survey, but it should be covered. You should have a base level of knowledge that goes along with this. So first part of our primary is airway. And airway is on the top of the list, starts with an A for a reason, because without a patent airway, our patient's going to die within a few minutes as opposed to several minutes to hours. So we're going to assess our patient's airway patency from across the room. We should, as advanced practice clinicians, be able to walk in a room and tell if somebody's having difficulty breathing, whether it be they're in the tripod position, if you have upper respiratory stridor, the high-pitched inspiration, wheezing. Sometimes you can even get some crackles if you have a CHF or pulmonary edema that is progressed enough to have audible crackles. That's what we're going to be doing with the first thing when we see our patient across the room is assessing our airway. Is the patient able to maintain it? Also, along with this, in our protocol, we also have assess for possible spinal injuries. And when you do that, you're going to be able to see if there's something going on, because as we all know, the clear-cut medical patient is never the clear-cut medical patient. In some cases, you may have a medical trauma. You could have the chest pain that started and made the patient fall and them hit their head. There's a whole bunch of possibilities, but that's something you want to keep in mind when you're checking for airway patency, foreign bodies, things when you get a little closer to your patient. So moving on, we have breathing. Breathing, these are gleaned from another source other than our protocols. I felt it kind of demonstrated a little more systematic and in-depth way of presenting it. But we're going to always look at our breathing and anything abnormal. We've been doing this long enough that abnormal should pop out really fast. So we're going to assess for respiratory distress, anything out of a range of 12 to 20 breaths per minute, below or above, tachypnea, bradypnea. Our pattern, talking about like Kussmaul, Cheyenne strokes, any of those kind of breathing patterns that are indicative of abnormal disease processes that are going on, like DKA or head injury, things like that. Strokes and whatnot. Chest wall movements and symmetry, that's a big thing. You can always have the spontaneous pneumothoraxes, throat-PEs, things like that that can alter the symmetry and depth of our respiratory rates. And we always want to be cognizant of those because those go undiagnosed very in the EMS world fairly frequently, and that's something as advanced practitioners we should be able to pick up on very, very quickly. Also, we're talking about chest percussion, those things, lung auscultations, all of this stuff should be kind of come into the same assessment sequence as you're looking at the patient's chest. We should always listen to the lungs just in case. And then we're also going to be looking at pulse oximetry. One of the big things is 94%, anything below that. We want to definitely add supplemental oxygen. We're going to talk a little bit more about that briefly, but that is the general standard of care right now. So circulation, we're always going to be looking at circulation. Skin color and cap refill time, those are going to be big markers of what's going on in the very tiny vessels of the extreme periphery, especially the cap refill time. And as we all know, as our blood pressure drops, as systemic issues occur, we're going to start shunting blood to our vital organs. And all of that really occurs in our tiny, tiny blood vessels very early on. So once we start getting increased cap refill time and modeling and ashen color of the skin, those are really good hallmarkers of what's going on within the periphery of the body and if the patient is doing better or worse. So we're also going to palpate our pulse rate. And that's something that a lot of us miss out on, especially in the EMS world and within clinical settings, is we don't put our hands on the patients anymore. We throw that pulse ox on, throw them on the monitor, and that's good enough. It really isn't. We can't really determine the quality of pulse of the way the heart's working, what's going on in the periphery. Are we even able to feel a pulse in the on a radial pulse? Are we able to feel a carotid pulse? A lot of times we don't even put our hands on the patients until we see something going on the monitor where, oh, the patient's bradycardic, maybe we should check it, make sure they have a pulse. We see a weird rhythm on the monitor. That's something that we should be doing when we make patient contact while we're talking to them and introducing yourself. We should be checking respiratory rate and pulse rate and quality all within a very short amount of time, but it seems to go by the wayside as we get a little more practiced in a way and get a little lazy, honestly. So we also want to listen to the heart. And while not all of our medical patients are going to be cardiac, it's very imperative that we listen for those S1s and S2s, S3s and S4s. Those things do come up from time to time, but we don't hear them. We don't auscultate the heart frequently enough, honestly, within EMS and in clinical practices. And if you'll remember back to your first day as an EMT basic or the first days in clinical settings for nursing school, we did blood pressures on each other and we listened to each other's hearts and we assessed each other to essentially learn what normal is. Because once we learn what normal is, the abnormal stands out. We see these things, these strange things pop up and it's like makes us question, Now, we did that years ago. We should all be a couple of years into our practice as clinicians, And if we don't keep up that skill and understanding of what normal is, how are we going to be able to assess for the abnormal? So when we listen to the heart, we're going to listen for the lub dub, the whole thing right out of the textbook, the lub dub, lub dub. And those are your S1, S2 sounds. And then you get the S3 and S4 that are the Kentucky and Tennessee, showing mitral valve regurgitation or prolapse. And listening to those, when those pop up, it's very, very important to document that those are there, because it does show some issues that are going on, even though it may not be pertinent to the patient. It may be a new finding. So make sure you always auscultate the lungs for that. And if you haven't heard those S3 and S4 sounds, check it out on YouTube. There's a bunch of videos demonstrating the sounds that you're expected to hear. So the internet's an amazing resource for that sort of thing. So the next thing we're going to be looking at is blood pressure. So these things kind of really go down the way we should be assessing our patient. We'll be able to, from across the room, skin color, we walk up to the patient, we can check cap refill, palpate a pulse, and then to the heart, blood pressure, and at the bottom, the ECG. This is the way we should be assessing our patient in a systematic way. So our blood pressure, here it says systolic to 100, 140. That's as we talked about at the very beginning, that's just a base guideline. As advanced practice clinicians, we should really be looking at MAP instead, our mean arterial pressure. 65 or greater is really what we're looking for, because as we all know, depending on the patient's current problems, current health issues, we may have low blood pressure, and the lower blood pressures and lower MAPs, we start seeing drop off around a MAP of 60 on healthy patients. So we kind of want to have a little buffer zone at 65 if they already have arthrosclerosis in the kidneys or other organs that could, the mean arterial pressure may not be enough at 60. So we give that buffer of 65, and most patients would be fine at 65 unless there's already some severe systematic issues. So that's the big takeaway from that one. And then at the very end, we have the ECG, and we should be all fairly familiar, and you'll be reviewing that with, I believe, Mr. Crabtree in another video. So D is our disability in our primary survey. Again, this is going to be our neurological assessment, really. So our tried and true AVPU, alert, voice, pain, and unresponsive. That stuff is pretty early on in our training, but a good refresher. This is also kind of a precursor to our Glasgow Coma Scale. It's going to come in our secondary survey. So we're going to be looking at limb movements, and the big thing is focus on what's normal for the patient, what's different. Ask those questions. Is this patient normally only responsive to voice? Why does this patient have altered levels of consciousness is a big question that you want to ask right here, because that's going to lead you down to a different algorithm and clinical diagnostics than if it was normal for them if they had a stroke 5 years ago and they haven't been able to speak since then. So limb movements, what's normal for the patient? Are they ambulatory normally? Those kind of things. Pupillary light reflexes, what's going on in the patient's neurological status. Also keep in mind things like glaucoma, those are going to affect those, and we can basically find where our normal is, what our baseline is at this point with the neurological status. And again, always, if you have altered mental status, check out that blood glucose. That's even if they're in DKA and you have no way to, and they're bottoming out, giving them a half an amp of D50 is not going to kill them. But there's a lot of neurological issues and stress, and it's really bad for the patient when they're hypoglycemic, really low in the 20s and 30s. That's really bad for the patient, and we can fix a little extra sugar if they're hyperglycemic, but that's always something to keep in mind. If you are on the rotor and you get an unresponsive patient and you forgot your glucometer, that should always be checked though. Glucose should always be checked when there's a question of consciousness and if it's a non-normal altered consciousness. So last is our exposure. This is really geared towards our trauma patients, but when we, as we move into the rotor, as you as a clinician move into the rotor, you're going to run into more patients that are not necessarily the interfacility stuff. You're going to be doing a lot of scene calls that involve unknown medical type situations, as all the paramedics in the room may be able to attest to, that whatever you get called on is not necessarily the case. And once you get there, you may need to, if you have an unknown medical or unknown etiology of the patient, you're going to have to expose and examine, and it may just wind up being a stroke when it could have looked like the guy fell off his tractor, and that's what you got called on. So expose and exam is needed. And keep in mind, as indicated, we don't need to be stripping down every single patient that's got chest pain. Just the shirt is enough typically to put your 12 lead on and then cover them up for dignity's sake. If they have crowning in our OB status, feel free to expose there, but you need to just do what you need to, and don't be too excessive with it on our medical patients. But with trauma, everybody gets naked. So you gotta have to find all of the issues on that one. Our secondary survey, this is just, we're gonna talk about this. There's no breakdown on the slides because this should all be fairly review. So vital signs, that's a big part of our secondary survey. But you ask, Ryan, what is our, we've already done all of our vital signs. We've got heart rate, we've got breathing, we've got our blood pressure. We're already throwing this patient on a pulse ox. We've got all our vital signs. Yes and no. So the big thing with vital signs, and this is in our secondary survey and tertiary and quaternary and quinary surveys, as we continue on, the big thing about vital signs is trending. Yeah, I can take one set of vital signs and find out what the baseline is and what's going on right now, but we really need to be able to paint a clear picture of the direction the patient's going. Are they trending upwards? Are they getting better? Are they getting worse? Are our interventions actually working? Are they helping at all? Are they hurting? That's where this vital signs in the secondary survey really come into play. Is it's more about the trending data and getting a good patient picture for the receiving facility between the primary and secondary receiving facilities. So keep in mind, we'll talk a little bit more about this, but a minimum of every 15 minutes is required by our protocols, and you will get dinged. Your reports will get sent back, and you will be questioned why you didn't do them within a 15-minute interval, with some understanding that there are issues with monitors and things. But if you consistently monitor a patient at Q30, then it's something that may occur in ICU and post-surgical care and long-term care. 30 minutes is fine, but within the EMS field, things go downhill really fast, and you're in an ever-changing environment as you go down the road. So Q15 is the minimum at which we really need to be taking those vital signs. Now, within our typical transport times of 45 minutes to 2 hours around, you're going to get enough data within that period of time to actually develop some trends and to have a better understanding of our patient. And really, it's a big deal for our receiving facilities to have a good understanding of what happened between the two the facilities and what's going on. So Glasgow, we touched on that. As you develop your AVPU, you're going to start developing your Glasgow Coma score. And the big thing with this is some of our secondary and our primary surveys are going to cross over a little bit. We're going to be utilizing data from there. So we're going to develop our Glasgow Coma scale. A big thing on that is the old adage, less than 8, intubate. So just remember your Glasgow Coma scale and report it accordingly. And keep in mind that we just don't do it that one time, because a patient can start out at 15 and then move downwards and wind up at an 8 by the time you drop the patient off. And the big thing is trending data. We need to have a Glasgow on every single set of vital signs, every single assessment. Even though that may seem tedious, it's very imperative, especially with patients like stroke patients, septic patients, acute liver failure. Those things that really affect our mentation and can throw up some crazy metabolic processes and byproducts that can affect our mental status, is to have that trending data and to see how fast, how much time the receiving physician may have before they can send them off to surgery, or be a little more aggressive with their interventions. And if it's slow, they may play it a little more safe and be a little less aggressive in what's going on. Next is our chief complaint. And a lot of times that it gets really confusing, especially with our interfacility transports. We have the diagnosis from our physician, and we have what the patient complained of, and then somewhere in the middle, a lot of times, is what our impressions are. Sometimes they lean a little more towards the physicians. Sometimes they're a little more aggressive than what the physician said, or they find something else completely wrong based off the patient's chief complaint. Now, the big thing on the patient's chief complaint is it's the patient's complaint. What are they complaining of? Did the patient come in with by EMS with shortness of breath, and then found out they have a PE? Now, the diagnosis is going to be pulmonary embolism, but that's not the patient's complaint. The patient's complaint is shortness of breath or difficulty breathing, or however they want to document, or you want to document it. That's what the complaint is. Now, when we get into our field diagnosis, and as you start getting into our reporting system, and I'm sure there's other reporting systems out there that are very similar, but you'll see that there's a big separation between our assessment, the diagnosis of the sending facility, and the patient's chief complaint. And all of these are very pertinent for documentation and trending data. If the patient's chief complaint is alleviated, what's now going on? Are they complaining of shortness of breath? Now they have leg pain. Things like that. That's stuff that you really do need to document and keep a good eye on. Then moving to our history of present illness, that's kind of what's going to be our big story time. What we get from the sending facilities, nurse or physician that's giving us report. Did they come in by EMS? Did they go to this CT scanner first off right when they came in? What did EMS do while on scene? Did they get lines going? Did they have issues extricating the patient? That kind of stuff is where we're looking at for the history of present illness, HPI. What's the story is a big deal on that one. And then we move to our sample, and that's our old buddy sample: signs, symptoms, allergies, medication, pertinent medical history, last oral intake, and events leading up. So all of that needs to be assessed and documented, and there's places in the report where in our reporting system where all of those need to be documented. But it's very important that you ask these questions. A lot of times what we run into is these small town hospitals that have the nurse prac that's been working for 2 years, and they're the only upper level clinician there, aside from a physician that's 45 minutes away in another town. And not to discount these guys, but we're used to that acute care. We're used to all of these kind of things, and we really need to focus on doing a full assessment on every single patient. And I know back in the day when I was writing the box, a big thing that kind of ticked me off always was what I perceived as the nurse that was taking report from me as not listening when I told them the patient had allergies to sulfa drugs and penicillin. But really, what they were doing was doing a full assessment. That way, they make sure that nothing was missed, because that patient always and what made me realize that was patients always tell them something different. They may remember that they had a allergy to sulfa medications, or they had diabetes, or they just forgot to take their blood pressure medication that day. Stuff like that happens all the time. And when you call 911, you've got that big bump of adrenaline going on, and you have all these people show up at your house. It's very easy to get flustered, especially if you're having a serious medical emergency. Now, I say all of that to impress upon the point that you really need to do the full assessment on your own as well, because you're taking a patient from one facility to another, and there's you're the stopgap between that. Your documentation as what's going to fill in the void in that patient's medical history. And it really needs to be very well documented, and you need to do a great medical assessment, because those physicians may miss something, or those physicians, nurse pracs, PAs may miss something because they're not used to that acute level of care that we are, and we're that fill-in for that patient for time missing outside of the clinic. So just keep in mind good assessment, and then a systematic head to toe. If you now I bolded and italicized the systematic because it really needs to be a system. If you don't do some things the same way every time, then we're going to have you're going to miss something eventually. And just personally, the way I do it, and I do this on medical patients, even though they may not have a complaint of anywhere else on their body. It's just chest pain or broken pinky toe. We always need to do this systematically. And what I do is I put my hands on the side of the patient's head, and I look into their pupils, and I slide one hand behind their head to feel any decap BTLS, if you remember that from EMT Basic. I look at my hand for any blood. I look at the ears, and at that point you should be looking at the patient in an inline way, and you can determine JVD for pneumothorax, hemothorax. Pericardial tamponade, tracheal deviation for the former, all sorts of stuff that you can tell from that point. Assess for spinal injuries, as we touched on earlier with the airway. This can all happen kind of simultaneously as you're doing your basic, your primary survey. So along with the finishing of the systematic head to toe, you look at the chest, equal symmetric rise. All of that stuff needs to be documented in your secondary survey. And just to have a good understanding of what could be going on with the patient. If they have a PE, but they're actually throwing clots all over the place, now they have a deep vein thrombosis down in their right leg, the physician may not have noticed that because he never got past breathing. So always do your full head-to-toe assessment and make sure that you've got that well documented. So initiating medical care, this is really going to be kind of geared towards the rotor, and but it does happen with a lot of interfacility too. The understaffed area, small town hospitals, you may basically be doing a home call, a 911 call. If the staff is backed up with other stuff going on, you may not be able to get a full report from them. So a lot of this is a crossover, and we're going to see how much it's basically just repetition in a lot of ways. But all of this occurs simultaneously. That's the big thing about initiating medical care and doing your primary and secondary assessments is you're going to be fixing problems as they arise, especially in our A, B, and C's. We need to fix these problems now if they're affecting any one of those. And as we go down further in our assessment, we can slow down a little bit with the dramatics. We don't have to throw down, crack this guy if the guy is neurologically unstable at that point. If he's got a foreign body in there, we're at airway and he's got a foreign body in the back of his throat, we can't get it with the direct laryngoscopy. Yeah, let's go to the crack at that point. That's where as you move down your ABCD, you become less aggressive, is I guess the best way to put that. So move to establish and maintain a patent airway. That's the big thing. Airway is always first. Our airway is very important. And this, again, is pulled off our SOPs. All patients should receive supplemental oxygen. Now, there's been a lot of stuff in the last several years, last decade or so, that's come out and said, oh, free radicals. We've got a bunch of free radicals when we're giving these patients non-rebreathers at 15 liters a minute, and it's adverse for patients' long-term well-being, and it actually can exacerbate disease processes and all sorts of things like that. Yeah, it's really, really bad. But hypoxia is a lot worse. And now that you're going to start working in the aeromedical field, we're taking these patients up to altitude. And all this stuff should be covered in flight physiology with Mr. Adams. But it's important enough that it bears repeating in our general medical patients. So all patients should receive supplemental oxygen. And the importance of it can be really known once you start flying a little bit. We have duty times for our pilots, and we have duty times for paramedics. We're not allowed to do 48 doubles. We have to have at least 12 hours rest or 10 hours rest between shifts. These things are important and are part of the FAA's regulations and are part of CAIM's regulations because of fatigue. Now, I know not everybody in the company or that practices air medicine is at peak health, but if you think about that, we are much healthier than our very sick patients and our moderately sick patients, and we still experience fatigue. We're not using our extra ATP and our extra oxygen to fight disease processes, and we still experience fatigue. We still experience mild hypoxia at altitude. So it's very imperative that we, at least at the very minimum, put a nasal cannula on our patients. That way we can keep them in a good oxygenated range. We alleviate any chance of hypoxia. And that's the big thing, is we don't want to get into that state, because it's a very quick amount of time, a very short period of time where we start seeing adverse effects of hypoxia. Moving on to our end-tidal, we talked about our products of aerobic metabolism and an anaerobic metabolism. If we don't put that supplemental oxygen on, we're going to have an increase of anaerobic metabolism. We're going to see a huge jump in acidosis, and we're going to start having a rapid respiration, drop in target CO2. So we really need to make sure that we cover all of that. And with our intubated patients as well, we need to make sure that we're adding some supplemental oxygen too. A lot of the study data that comes out is we want to keep them at a low 21% if at all possible. But that's almost impossible even with even some of our healthier patients when we bring them up to altitude. Even on the rotor wing, you're flying around at 1,000 feet, we still see some drop in SpO2 in our patients, and an alternation in our target range of end-tidal CO2 monitoring, which is 35 to 45. We want to make sure that we maintain that with our normal ventilated patients, and it's a really good assessment tool. It's become the standard of care for their end-tidal CO2 monitoring. It's been a blessing in EMS over the last several years. It's really helped us out with our assessment and understanding what's actually going on with our patients, even if it's even outside of respiratory issues. You could be looking at sepsis and seeing increased end-tidal CO2 because of all of the other disease, all the anaerobic metabolism that's going on from in a systemic situation. It may not be the respiratory system's too slow to breathe it off, but the body's working that hard to try to get rid of all, and has a buildup of CO2 because the anaerobic metabolism and everything else. So keep in mind, again, that 35 to 45 is just for a standardized ventilator patient. It's not head injuries, and you're going to be wanting a 30 to 34 on our head injuries. That's should be covered in our trauma and our ventilator management video series. So, and moving forward, if you're unable to innovate and establish an airway project, progress to an airway adjunct, that's kind of talking about our endotracheal tubes as well. We have our King tubes. You may run across a combi tube out there. There was a big series of them that didn't have any expiration dates. So I've actually ran on a couple of patients that do have those combi tubes still. But the King tube, what we have, is really great. It's really easy to use. Should cover those in your skills or in the airway section. But it's a pretty good tool. And if that's unable to properly ventilate the patient, we can look at our surgical cracothoratomy. And first things first always is let's throw OPA in, let's ventilate with the BVM, get the patient up to, get the patient's SpO2 up as high as we possibly can, and then we'll look at those surgical cracothoratomies. So that's part of this, again, a blatant copy off of our SMPs. So just so you have an idea of where this says, and use your clinical judgment. If you think this patient is a crash airway and we need to crack right now, crack right now. I mean, it's based off your clinical judgment. And as long as you have supporting documentation and to lead to these variations from our protocols, you're going to be backed up 100% as long as you're following good clinical judgment and good clinical practice. So verifying the tube placement and intubated patients are something we run on a lot. So these are all things that need to be documented. End-tidal always is a big thing. That's going to be our primary marker, especially with our waveform capnography. We used to, back in the day when we were running like Johnny and Roy 911 services, we have to, every time we moved the patient or the patient made a weird shimmy while we're bouncing down the road, verified tube placement through auscultation. Now with the end-tidal waveform capnography, we're able to just look over at the monitor and make sure he's still throwing CO2 with every respiration and it's still in place. So that's going to be our big primary method of verification, but we also want two more. And I always like the, and something I was taught early on in my career was you want a mechanical test and a visual or a tactile test. So visualize through the cords is a visual or tactile auscultation, is equal breath sounds and chest rise and expansion, absence of gastric sounds. Those are all tactile visual. And then mechanical is our post-intubation chest x-ray, changes in our colorimetric devices before we had our end-tidal, and end-tidal can cover that mechanical as well. We do carry those colorimetric end-tidal CO2 devices, and it's really more of a verification that our monitor may be malfunctioning. It's really just a backup, if you will, and to verify that our monitor is in fact malfunctioning and it's not a missed tube if everything else is showing correctly, expansion of the chest rise and all that. So mist and fog, though, is not a criteria for confirming tube placement. That's something that's very important. As we all know, we've ran codes where the patient wasn't intubated, and we've bumped them up. We've bagged them so much that their abdomen is extremely distended. And if we intubate down the epigastrum, we may indeed get some misting in the tube, misting and fog, because there's air in the stomach, and it's has a means to get out at this point. So just keep that in mind, that misting and fog is not a criteria for confirming tube placement. So conduct a general assessment of the patient, primary and secondary. This is where this crossover is actually on text. Document patient assessment at a minimum of Q15. Now, when it says, we touched on this, it says patient assessment, we're talking about our vitals, our secondary, tertiary, quaternary assessments. Our Q15, run the vitals, look at our patient, check the pulse, make sure that they're in good straits or correct if they're not, or pat yourself on the back if they're doing better. But we need to be documenting these. I've actually run on patients where I was actually taking their vital signs at Q5, but only documented at 15. I was concerned about the patient, but really didn't garner the plethora of different vital signs, the 100 and some odd vital signs that I actually took over the time that I was taking care of the patient. But there was enough data within the 15 by doing it at Q15 and documenting that. Luckily now we actually have the ability to transmit our vital signs from the monitor to our documentation software through Zoll, which is very, very, very nice. And But just keep that in mind that we need a minimum of 15 minutes, but we can do it much faster. Place patient in a semi-Fowler's or position of comfort unless contraindicated. Now, where that this is kind of a vague catch-all, and to give you a little leeway, we find our patient position of comfort. You think of our patient being in a semi-Fowler's and getting hypotension because they're pregnant. That kind of thing happens, and then we need to place the position in a position of comfort because it's the best thing for the patient. Placing them in a position of semi-Fowler's also helps with breathing status and all sorts of things. That's where we want to kind of be at. Even with our intubated patients, you have to think about the vast majority of America is obese. We have a bad habit of laying all of our intubated patients flat supine. If you think about all of the weight from the abdomen is pushing up against the diaphragm when you lay them supine, then you're going to get decreased respiratory compliance. And that's a big deal. I've noticed a patient from moving them into the aircraft and having them lay them flat and then setting them back up, not changing any ventilator settings, but be throwing high pressure alarms, going high drop in SpO2, and then all of that being alleviated as soon as I sit them up just a little bit, just because their abdomen was so large and putting pressure and decreasing compliance of the lungs. So just keep that in mind. That in mind with all of our patients. Semi-Fowler's is the best position unless contraindicated or if they're completely uncomfortable. And also take that with patients that are on backboards. Granted, this is the medical video that you're going to go over, but adding a little cushion behind their back, or if they've got something going on with their, say, severe pedal edema and it hurts to have any pressure on it. If they're bouncing up and down the runway and when we take off, a little extra padding won't hurt. That's also kind of covered in this position of comfort unless contraindicated. So keep all of that in your mind vault of tools to add a little cushion or make the patient as comfortable as possible, because pain is just it's something that we can avoid. We should. We'll talk a little more about pain management shortly. And keep your patient comfortable using blankets or sheets. There's a lot of disease processes that use a lot of our energy. Like sepsis is a really good example. We're losing a lot of energy. We're running at a high metabolic rate trying to fight off this all of the invaders and infection. And our patients are going to be hot. So a thin sheet may be a little more applicable than the big thick wool blanket. Just kind of keep that in mind. We do experience some extremes up in the Texas and Oklahoma panhandles and wherever we expand on in the future. All of this area has extreme winters and extreme summers where we go to get into the teens in the winter and triple digits in the summer. The weather does have a huge effect on our patient care. So remember to use cool packs if you need to. Remember to have extra blankets. Use the cocoons. Those are really cool tools, especially in the rotor. We don't have the insulation that the fixed wing does. So we need to be mindful that the patient needs to be covered up or allowed to have some cooling processes, the ability to kind of cool down. And it's more about the patient's comfort than your comfort, because we're quote unquote healthy people, and we can deal with that. The patient shouldn't have to. So, and then begin pulse oximetry monitoring. Again, there's that crossover. So appropriate, these are both the EZ-IO here and the intravenous access. Both of these are kind of big bullet points. They're big issues that we want, since we are a critical care specialty transport system. This is one of the big pertinent deals, is having IV access. So we're going to talk about this in Easy IO in a little more depth in the last few bullet points. Appropriate IV access for all of our patients is imperative. IV infusions will be continued as ordered. Again, remember what we talked about before. If you need to change your Levofed drip, increase it, decrease it with new patient changes, then that's okay. You've got the backup of standardized health, a standard of care that will allow that kind of variation. You'll never be questioned on it. Blood products will be continued at the rate initiated by the transferring facility. That one's kind of really don't have a leeway on that one. It's not a running blood in versus running it at the rate that the facility sent it at. Typically, they're going to be running it as fast as possible anyways. So just keep that in mind, that we'll be continuing it most likely at the fastest rate that you can possibly get it into, or make sure you assess for signs and symptoms of transfusion reaction, the pyrexia and all of those things. Supporting documentation for absence of IV access should be recorded on the flight record if access is not obtained. So this says flight record, but really what it's saying is your report, your medical report. Make sure that it's put in there. I know some people call in to dispatch on the recorded line and state, hey, this patient doesn't have an IV. A lot of times that's for patient delay reasons, or transport delays. They're wanting to throw that IV catheter in there and make sure that it's there. Make sure that it's documented that there's going to be delay for patient care and quote unquote stabilization. But make sure you put it into the report system, because it's not going to always be a patient that needs an IV. We do a lot of transplant patients and a lot of repeat patients that are very chronically ill, that have physicians, specialty physicians in Dallas and Houston, that they go for a checkup every 6 months. Those patients don't need the IV. If it's Grandma Betty that's been waiting on a kidney for the last 2 years, Grandma Betty doesn't need an IV. She's just flying to Dallas to get her kidney. She'll get all of that stuff done when she gets there, and that way she's not poked and prodded any more than she has to be. Just make sure you document all of that in the report, why they didn't have it. And luckily enough, most of those trips this will be the case will be pre-approved, and insurance won't balk too much at not having IV place. And the bigger thing, big takeaway point from this, IV access in trauma patients should typically be done during transport and inter-facility prior to transport. Hopefully that's the case. This is a little bit dated. We do have the new Rotor Advance, the Rotor protocols and guidelines in the SMPs and SOPs, but this one kind of seemed to be a little left out. Prior to transport is the big takeaway. We don't have the room. In the fixed wing, you have access to the right side of the patient or patient's right arm. That's about it. Good solid access. You can always lean over the patient if you or attempt to lean over the patient and try for a left-sided IV catheter. But it's very difficult. Believe me, I've done it before, and it's a huge pain. So try to utilize the room when you have it. If you are picking up a patient from a scene call, utilize their ambulance. If you need to put an IV in or a secondary IV in, do it in the sending facility ER room or ICU. Just try to get that done before you lose that ability to have that extra room and extra hands as well. In the Rotor, you have even less room. You barely have access to that left arm, and you have no access to the legs without putting yourself and the patient at a very dangerous position. So it's very imperative that you get good solid IV access or IO access before you even take off from the ground. Just because you're not going to have a second chance at being able to get any of that. Solution, tubing, and rate are to be determined by the patient condition or as specified by SMGs or SOPs, or SOPs, SMPs, and SMGs, all the anachronisms that we have. That's a big blanket kind of gray area that we have in there to say all this needs to be done, and we can change it if we need to. Rate are to be determined by patient condition kind of things. We talked about that Levophed. If you need to go up on it, go ahead and go up on it. That's where that's being covered. All primary and piggyback fluids should be run at an appropriate rate, supported by the most readily available medical literature. We talked about that at the very first slide. If you've got the most readily available medical literature and it's a little different than what we have written down, this little clause covers you. IV pumps or other fluid restricting devices should be utilized when supported by current medical references unless rapid fluid resuscitation is indicated by SMP. That's a lot of words saying basically you need to use a drip set with a pump 100% of the time unless you need to just dump fluid in. And we always need to use some sort of IV bag adjunct because of, if you remember from, I believe Mr. Adams is doing the flight physiology, you remember Boyle's law. Even with pressurization, we're not going to, of the fixed wing aircraft, just free flow IV drip is not going to work. Even if you've got that thing wide open, it's not going to flow because the changes in pressure. It's just not how it works in the aircraft and aeromedical world. So you need to have at minimum a pressure bag if you're just running a TKO rate, preferably and demonstratable later down the road. If you run into an issue, having I'm losing my words now. Having an IV pump, having an IV pump on there is a lot safer and a lot more easily to verify the rate and kind of protect yourself from any adverse. If something bad goes with the patient, they come back trying to sue you because you over medicated a patient on a particular medication. So you dumped a whole bunch of dopamine in a patient and they coded because of that. If you have them on a pump, you can demonstrate through your chart, and I believe it can actually even be pulled up on the pump, what rates were on some pumps, what rates were actually being infused at a particular time. So all of it's very verifiable, and you can cover yourself in case of legal issues. So, and here we have our guidelines for EZ-IO. And keep in mind that these are, both of these here are essentially just kind of covers when you need to use an EZ-IO, but use your best clinical judgment on this. But this is a very, very, very good jumping off point on when you need to use an EZ-IO. So in adults greater than age 8, consider an IO if access is needed and cannot be established within 2 attempts or 90 seconds, 2 attempts, 90 seconds, and in patients who exhibit one more of the following. So emphasis on and, so 2 attempts and altered mental status, respiratory compromise, and hemodynamics instability. And basically saying we need IV access, we need a route for medications and fluid now. Is it really the good takeaway from that? Here in a few minutes, the patient's going to crash, essentially. This one is, we need it right now, we need it yesterday, we're already behind the 8 ball. So considered after 1 failed attempt and to establish in cardiac arrest, medical or trauma, doesn't matter, or profound hypovolemia with altered mental status. So we need the fluids now. The patient needed fluids last week kind of deal with this one. So that's our big covering on that one. Pain management. It's actually one of my favorite topics as I've been teaching over the last couple of years is pain management. It's something that as a basic, you watch paramedics being able to do at least from my standpoint, when I was starting out, being able to alleviate a lot of issues just by sheer pain management. It's one of the few things that we can really, really affect our patient outcomes and our perception of us, is being able to deal with pain and give pain medications. Because we all know when we get to the ER, the nurses probably know it better than even the paramedics, but they're going to have to go through the physician's going to have to see them, then draw up the orders. The pharmacy is going to have to pull out the medications and bring it up, and then the patient's going to have an IV if they don't have one, and then it's going to be several minutes before the patient actually gets, any relief from from their pain. But us as pre-hospital and intra-facility practitioners, we can fill in that stopgap with our pain management protocols and really, really affect our patients' outcomes, because a lot of times we're not relieving the patient's pain enough. There's still some latent effects of pain that are shown in our vital signs that could actually be covering up a very serious medical complication. As we all know, responses to pain are tachycardia, increased blood pressure, all sorts of things like that, increased respiratory rate. All of those are effects of pain that could mask some severe issues. Now, keep in mind that if we really completely relieve a patient's pain, it may not be able to be determined. Back in the day, they used to say no pain medications for abdominal pain. That because of this, the assessment signs that you can do, but that's it's really fallen out of favor, and you only really see physicians complaining about that in really small, very, very small rural facilities. But we won't be really dealing with that kind of issue. So pain medication for all of our patients, but we don't, like I was saying, we don't want to alleviate all of the pain, because there may be it may be a compensatory mechanism that's keeping them alive. If that fast heart rate, we want to get them down to a 1 or 2 fast heart rate, may be keeping them alive, and that bolstered blood pressure may be keeping them alive. Pain management is a big deal, and we want to do the best we can for our patients, but we want to attempt some basic comfort stuff first. Repositioning, we touched on that a little bit. Padding backboards, changing the angle of the semifowlers, all that stuff. Confirm the NG tube is ventilated. Nothing's worse than feeling bloated. We've all had a few too many beers and just really felt our abdomen being extremely distended, and just throw that TUMI syringe, open up the top, and throw that TUMI syringe in there, and see if you can pull up some juice, some gastric juice, to kind of alleviate that. Because once we get up to altitude, that Boyle's law is going to be in effect again, and it's going to cause some severe abdominal issues, and also can cause some respiratory compromise as the gases expand in the stomach. Also, reassurance is kind of a big deal. Anxiety can also exacerbate pain, and it's calming them down, letting them know that they're in good care, they're in good hands, they're going to good care, can be really helpful in managing some pain. And high flow oxygen is really underutilized in the clinical and pre-hospital setting. Granted, it's not as good as heroin or Dilaudid or anything, but oxygen does have a euphoric effect. In fact, they even have oxygen bars where you can just go hang out, sit on beanbag chairs, and breathe through a nasal cannula at 5 liters per minute and get really, really relaxed. The extra oxygen really does help with some pain management. Really, it's really good at bolstering already in place pain management, such as like fentanyl, morphine, Demerol, those things. Adding a little more oxygen, bumping them from 2 to 4, can actually alleviate a little bit of the pain and get them down to that 1 or 2 range instead of leaving them at 4 or 5. So, and without us having to give any more pain medications. So once we get to a point where we can't do it with, we can't alleviate their pain by just comfort and whatnot, we're going to look at a little bit more of a chemical means with our morphines and fentanyls. And here we have our dosage range. And keep in mind, this is based on our best clinical judgments. This is also the systolic blood pressure. That one's not as gray and vague as some of the other ones. You're really going to have to justify yourself with pain, with a systolic blood pressure less than 90 and giving pain medications that could potentially drop their blood pressure. You're really going to have to back that up with really good documentations. And I'd say if their blood pressure is below that, pain response may be on the lower end of their worries. So stabilize first and then give some pain management. So, and their pain response may be the only thing keeping their blood pressure at, just where it's at. So, with morphine, 2 to 10 milligrams is what our protocol says. 10 is a little up there. But we can give, it does say that in there. I would say 2 to 4 on our first dose, and as needed, but really pay attention, especially with our pain medications and any of our high-risk medications, our peak onset. Fentanyl, if I remember right, and as peak onset is about 12 minutes, morphine's about every 15 minutes. And really assess your patient. The big thing, I think it's on here, on the last portion here, initiating medical care here, pain management. Reassess your patient afterwards, but make sure that you're looking at the right time frame. 15 minutes for morphine is at best. These are patients that are, really healthy. A lot of the data for pain medications comes from the military, peak onset and half-life and all that stuff. That it comes from the military, and these are 18 to 25-year-old males in the peak physical condition of their lives. Now, if you've got a bunch of junky arteries and veins, and the heart doesn't work too great, like we see a lot of in our baby boomer, our large generation of geriatrics that are coming up, 15 minutes may not cut it. So really look at, start looking towards 20 minutes for morphine and 15 minutes for fentanyl. Fentanyl does have a lot of use in the trauma world because it inherently on its own, it doesn't drop blood pressure, but it does drop blood pressure through pain relief, which we can see typically. That's why we look at that, still look at that 90 systolic, but it really has a profound effect in higher doses outside of our pain relief dosage. We're looking at sedative doses, and then in conjunction with benzos, so our Ativans, our Verseds, those medications do show an exacerbation of hypotension when used in conjunction with fentanyl. So just keep that in mind. A lot of our sending facilities are going to be using fentanyl and Versed. That's kind of the favorite. Versed and propofol kind of are very common around these areas to be used, and they can really profoundly drop the blood pressure when you do give that fentanyl, because they don't always think about pain and management with the sedated, paralyzed patients. Keep that in the back of your mind when we start having those patients. You start having those patients that there may be a drop in blood pressure with the fentanyl, and keep that bolus of fluid ready in case it happens. Another thing that we don't talk about very frequently in pain management is really, you could call it discomfort management, because nausea is also on there, and that's something else that we can really alleviate in the pre-hospital interfacility world is nausea. And that anybody that's had a sick stomach, and I don't think if you're human unless you've had a sick stomach at some point in your life, it's miserable. So we can actually fix and help that. And riding backwards in a vehicle is never fun, and it's never conducive for comfortable rides. So Zofran prophylactic treatment is also a good idea. Always ask your patient if they get motion sickness, because even the patients that never been motion sick may get motion sick at this point, because just all the different movements in different directions and not being able to tell which direction we're actually going with our eyes can really mess up our spatial awareness and cause some nausea. So Zofran, greater than 16 kilos, 4 milligrams. Less 8 to 15 kilos, 2 milligrams every 2 to 4 hours is needed, and you can repeat it after 15 minutes. So repeat it after every 15 minutes, then again every 2 to 4 hours after that point. So Phenergan, keep in mind this is a first generation antihistamine, so it's very similar to Benadryl. It does have antihistamine properties, are basically chemically the same, and they cause the same reaction. I think there's just a minor variation with a hydrogen molecule. But adult is 6 to 12 milligrams, and you can repeat it one time, and then you can do that every 4 to 6 hours. It lasts a little bit longer. It does cause some sleepiness. The pediatric is half that dose, 3.125 to 6.25, and within the same parameters for repetition. But it's also an opioid agonist, so it potentiates any of our opioids, and both of our high-level analgesics are opioids. So if you're having some abdominal issues, stomach pain, it may be a good idea to throw this guy in there with 50 of fentanyl or 25 of fentanyl, something low dose, and see where it goes, because a lot of times the nausea is actually making the abdominal pain worse. And then we move on to our the rest of our initial medical care. Continuous cardiac monitoring is required on all patients. I threw the pain management in here because it kind of falls. Following up with this portion really kind of demonstrates what needs to be done with the monitoring of the patient. So continuous cardiac monitoring is on all patients. Follow all appropriate S&Ps. Do everything possible to maintain the patient's comfort and ease of mind. That's just normal general practice. And then follow every IV push medication with 10 cc fluid bolus, or 20 to 50 cc's if the patient's hypoperfused, and systematic shunting or any of that stuff, low blood pressure where there's some shunting in the periphery, sick heart, all that stuff. And just go ahead and run some fluid in with those medications, make sure it gets to the heart and doesn't stay stagnant in the periphery for a long time, because half-life of medications and whatnot. So, and then after every intervention, reassess and document patient condition. And like I said, we did the pain management before this slide because that's very imperative that we do that trending data. And I know I've spoken a lot on that trending, probably ad nauseum at this point, but the trending data is very important because we actually can see that we're helping the patient or hurting the patient. Really, it's helping. A lot of times, especially as a pre-hospital provider or an ER nurse or a clinician that works in the critical and acute care, we don't always get to see the good stuff that happens. But so make sure that we do the trending data and do what's everything that's appropriate and document all of it. Pain management scale 0 to 10, that stuff is very important. And then we'll refer to your sedation maintenance that's on there. I believe Mr. Crabtree is going to cover all of that for us in a different video. But that's it for me. Here's something that covers that, and check out your pain management protocol for that, and just utilize Narcan if you need to reverse it. Really kind of the big takeaway from this. Monitor, check the patient's blood pressure 5 minutes after administration, because you can get that big drop. But review these S&Ps on your own, because there's a lot of information that was just thrown at you, and try to have a good day.